Good morning. Today we'll be talking about hemolytic anemias, and the learning outcomes from this presentation are to get familiar with the definition and classification of hemolytic anemias, become familiar with the normal physiologic response to hemolytic anemias, and get introduced to various hemolytic anemia conditions. The outline, essentially, we start with the definition and then go to the various classification methods we use in hemolytic anemias, the physiologic response to hemolytic anemias, and finally specific clinical conditions that lead to hemolytic anemia. So by definition, hemolysis is essentially increased destruction of red blood cells. We can generally classify hemolytic anemias into two main large categories, what we call immune-mediated hemolysis or non-immune-mediated hemolysis. Simply, with the immune-mediated hemolysis, is the immune system that's destroying the red cells. With non-immune, it's independent of the immune system. And under each of these categories, you're going to see has multiple conditions that lead to that. With the non-immune mediated hemolysis, also we subclassify them into processes that are due to a process outside the red blood cell itself or due to a defect in the red blood cell itself. So what we call extracorpuscular versus intracorpuscular. And the extracorpuscular can happen in large vessels, macrocirculatory, or small vessels, microcirculatory, while the intracorpuscular are a defect in the red blood cells, either in the membrane or in the hemoglobin itself. The immune-mediated also, we subclassify them into two large categories, what we call the cold agglutinins and the warm agglutinins. And essentially, these are autoantibodies that bind to the red cells and destroy it. And these antibodies, they can function optimally at different temperatures. The warm agglutinins function optimally at 37 degrees, while the cold agglutinins usually function at lower temperature, and each one of these has different also disease entities that lead to it. So as a background, as you know, we have a normal red cell destruction in our body. This is what we call random hemolysis. The red cell, when it's released from the bone marrow, it essentially has lost its nucleus and DNA, and has lost its ability to produce new enzymes and new proteins. So whatever that red cell is born with at the time of release from the bone marrow, it's going to slowly consume over time. So as it gets older, it will have less and less enzymes, it will have less and less flexibility, it becomes more stiff, and as it gets older, it gets picked up by the reticuloendothelial system, mostly in the spleen, and gets destroyed. And this process called random hemolysis, the usual red cells survive usually for around 100 to 120 days. So what happens in the spleen, as you recall from histology, the spleen has two main parts, the white pulp and the red pulp. The white pulp is responsible for the immune function of the spleen, while the red pulp is where the red blood cell destruction happens. So what happens, the red cell arrives through the splenic artery. It gets squeezed into what we call the splenic sinusoids. These splenic sinusoids are full with macrophages. And if the cell is young, still biconcave, flexible, it can easily squeeze through these sinusoids, exit the sinusoids, and go back through the splenic vein without any changes to its shape. If the cell is older, it has lost its biconcave shape, is less flexible, it gets picked up by the reticuloendothelial system and gets destroyed. This is the normal destruction process of the red cells. And we have ways of measuring the process of hemolysis in the body. We can radiolabel the red cells with a radiolabeled material called chromium-51. And so you inject the body with a chromium-51, and this will tag the RBCs, and we can see where that chromium went. And on the top part of the slide, you see are the curves that happens in various conditions. So the yellow line represents the normal degradation process of chromium. Chromium is a radiolabeled material, so it has a specific half-life. That radioactivity will go down slowly over time. The green line represents the process due to random hemolysis, because some of this chromium gets, these red cells, they get destroyed in the reticular system. So you see a little bit more rapid disappearance of the chromium activity from the body. The red line represents the process of hemolytic anemia. It's a much more rapid destruction of the red cells. You see a significant decline in the chromium activity in the body. And what you can do, you can scan the body, that's what you call red blood cell scan, looking for the site of the chromium activity. And this will give you an idea where the hemolytic process is happening. So you can see on the bottom part of the screen, like for example in hereditary spherocytosis to the left, most of this process happens in the spleen. So you see a lot of chromium activity in the spleen. While to the right, in the autoimmune hemolytic anemia, the destruction happens in both the spleen and the liver, so you see increased activity in both the spleen and the liver. Note that we don't routinely use these chromium scans in our daily practice. It's not a very convenient test to do. It's mostly reserved for research purposes. Importantly, hemolysis could happen, the normal process in the extravascular space in the macrophages, or it can happen intravascularly in the blood vessels. When extravascular hemolysis happens, essentially the splenic macrophage picks up the red cells. You can depict it here on the left side of the screen. The yellow is a splenic macrophage. It picks up the red cells and essentially destroys it into its individual ingredients. So the protoporphyrin gets converted to bilirubin, namely unconjugated bilirubin. That unconjugated bilirubin gets conjugated in the liver and excreted in the biliary tree. The conjugated bilirubin gets excreted in the biliary tree into the intestine. So you can detect most of it gets excreted in the stools as stercobilinogen. Some of it gets reabsorbed through the enterohepatic circulation and excreted in the kidney as urobilinogen. So essentially, protoporphyrin, unconjugated bilirubin, conjugated bilirubin, and it gets excreted as either stercobilinogen or urobilinogen. The iron gets transferred back to transferrin in the plasma, and that transfer will deliver iron back to the bone marrow to make new red cells, or to the liver to store it as ferritin. The globin is a protein, so it gets degraded to its individual amino acids, and these amino acids get used again to make new proteins. So you can see this normal hemolytic process is a perfect system. It essentially reuses and recirculates whatever ingredients we have in the red cells. You don't see any iron loss. Everything gets reabsorbed, so the patient does not get iron anemia from the extravascular process. On the other hand, with intravascular, to the right side of the screen, this is when the red cells lies within the blood vessel itself. So you see all the ingredients of the red cells, they get released in the blood vessel. So you end up with a free hemoglobin in the blood. This is what we call hemoglobinemia. Okay. Some of this hemoglobin gets converted to what we call methemoglobin. Essentially, in hemoglobin, the iron is present in the ferrous state as 2+. When it gets converted to the ferric state as 3+, this is when hemoglobin becomes methemoglobin. Okay? Some of this hemoglobin gets excreted in the kidneys into the urine. So you see free hemoglobin in the urine. That's what we call hemoglobinuria. Okay? And some of that hemoglobin, before it goes out in the urine, gets reabsorbed by the kidney tubule cells, and where it gets converted to hemosiderin. Okay? And when these tubule cells are shed in the urine a few days later, you can detect that in the urine. This is what we call hemosideриnuria. So essentially, with intravascular hemolysis, you see free hemoglobin in the blood, hemoglobinemia, free hemoglobin in the urine, hemoglobinuria, and free hemosiderin, and hemosiderin in the urine, called hemosideриnuria. Very important fact is that anytime you see intravascular hemolysis happening, this tells you there's a massive hemolysis happening. the usual, the milder form hemolysis usually start extravascularly, where we recirculate everything. It's only when the extravascular process gets overwhelmed you see intravascular hemolysis. So anytime you see an intravascular hemolysis, meaning there is always extravascular, but the system is overwhelmed, that's why you start seeing intravascular hemolysis. Again, an important differentiation point, when you lose hemoglobin in the urine, so you're losing iron with that. So patients who have intravascular hemolysis, they can have iron deficiency, unlike extravascular where the iron gets reused. So this is an example, essentially this is for example in sickle cell, where you have unstable hemoglobin. The unstable hemoglobin gets deposited in the red cells, what we call them Heinz bodies, unstable hemoglobin, and this will lead to a abnormal, stiff red blood cells. It goes to the splenic macrophages and gets degraded as extravascular hemolysis. With intravascular hemolysis, the cell lyses within the blood vessel itself, so you have release of free hemoglobin. Okay, some of this hemoglobin gets bound by haptoglobin, so it's essentially forming hemoglobin haptoglobin conjugates. So this will rapidly consume haptoglobin, so haptoglobin level goes down. So as I mentioned in the previous slide, you have free hemoglobin, hemoglobinemia, hemoglobinuria, and hemosideриnuria, and also you end up with low haptoglobin level when you have intravascular hemolysis. So indices of increased red cell destruction, when you destroy red cells, essentially, as we mentioned, you have increased unconjugated bilirubin and conjugated bilirubin, shortened red blood cell survival, and of course this results in anemia. You have increased urine and stool urobilinogen and stercobilinogen, and you have increased serum lactic acid dehydrogenase. This is a very important. LDH, lactic acid dehydrogenase, is an enzyme that's ubiquitously found in almost all of our cells. So anytime you have cell lysis, the LDH goes up. If you have hemolysis, if you have a heart attack, or major trauma to the seizures, for example, a lot of destruction of muscle cells, the LDH goes up. Okay, and I personally found this a very, very useful test when you're dealing with hemolytic anemias, because it not only tells you there's cell destruction, it gives you an idea about the extent of destruction. So it's a very easy test to do in every lab, and you can monitor the LDH level in patient day after day. It gives you an idea, are you doing a better job in controlling the hemolysis or not? If the LDH goes down, meaning the hemolysis is slowing down, and so on. More importantly, if somebody comes to you with suspected hemolytic anemia and the LDH is normal, it's very unlikely to be hemolytic anemia, because you need to have a high LDH. So a normal LDH essentially rules out the destruction process. So these 5 entities, you see them in both extravascular and intravascular hemolysis. Items 6, 7, 8 are seen mostly, essentially in intravascular. We see hemoglobinemia, you have decreased haptoglobin, hemoglobinuria, and hemosideриnuria, as we mentioned before. What happens to the bone marrow? The bone marrow is responsible for making the red cells. It senses there is an element of shortened RBC survival and anemia, so the bone marrow will make more cells. Okay, so it starts making, what happens is the kidneys will release erythropoietin. The erythropoietin level goes up 5 to 6 folds. So there will be reticulocytosis and release of reticulocytes from the bone marrow. And there's always also the reticulocyte shift, the process that we spoke about in the previous lecture, where the red cells, the reticulocytes, are released sooner from the bone marrow before they're fully mature. And we have several tests that can tell us about increased red cell production. As you mentioned, reticulocytosis, the reticulocyte count goes up. Polychromatophilia is essentially variation in the color of the red cells. Anisocytosis, variation in the size of the cells, and poikilocytosis, abnormal shapes of the cells. So, and why do you see that? Probably a good example to explain. Let's say you work at a restaurant, you make sandwiches, okay? and somebody comes to you, they want a shawarma sandwich, for example, and you have only one customer who wants one sandwich. You take your time, you make sure it's a perfect sandwich, you wrap it very neatly, and you give it to that customer. On the other hand, you have another customer that comes to you, they want 100 shawarma sandwiches, and you have like 1 hour to make these 100 sandwiches. You will be in a hurry. So the sandwiches, they will not be best in their best shape. You see some variation in their ingredients, you see some variation in the wrapping and so on. Some are a little bit smaller, some are a little bit bigger wrapping. So you see a lot of variation, and this is essentially what happens in the bone marrow. When the bone marrow, there's a lot of demand on the bone marrow to make red cells. It's starting to making messy red cells. Some are bigger than others, some have more hemoglobin than the others, some have different shapes than the others. Okay. Number 5, you see nucleated red cells also. So we almost always in our body we see some nucleated red cells that get released before they lose the nucleus. As soon as they make it to the spleen, the splenic macrophages will pick up these and get rid of them. But when the system also is very overwhelmed, you see a lot of nucleated red cells, you might see them circulating in the peripheral smear. Number 6, basophilic stipplings. The basophilic stipplings are essentially ribosomal deposits from the bone marrow. Ribosomal deposits in the red blood cells. Essentially, again, as a sign that these red cells have not fully matured. So you can see some ribosomes inside them. When you do a bone marrow on these patients, the whole erythroid machinery is very active in making red cells. So this is what we call myeloerythroid hyperplasia. Sometimes the bone marrow is so active it starts making even more neutrophils and platelets. So this is what's called neutrophilia and thrombocytosis, but this is not a common finding. And this is a picture of the basophilic stipplings, essentially these bluish dots that you see them at the periphery of the red cells because of the early release of the red cells. You've seen this slide in the previous lecture. This is a normal peripheral smear, nice, very well equally shaped red cells. The central pallor is less than half of the diameter of the red cells, and the platelets are in between. There's no variation in the size or in the shape. When somebody has hemolysis, either intravascular or intravascular, some of these cells, when these cells they go into the reticular endothelial system, the splenic macrophage will take a bite from the red cells. So when a small portion of the red cell is taken, it loses its biconcave structure. Instead of remaining biconcave, it becomes spherical. And it loses some of its volume because a portion of it was taken up by the macrophage. So this is what we call microspherocytes, small spherocytes. And this is typical process in hemolysis. When you see this is the normal red cell, and this is the spherocyte. You can see they lost the central pallor and they're smaller inside. This is what's called microspherocytes. As causes of hemolytic anemia, so as I mentioned, for the non-immune mediated, we look at them as extracorpuscular or intracorpuscular. With the extracorpuscular causes, this destruction could happen in the large blood vessels, macrocirculatory, or small blood vessels, microcirculatory. So in the macrocirculatory, the most common is essential hypersplenism. For example, somebody with liver cirrhosis, because of the portal hypertension, they end up with a large spleen. That large spleen will be destroying cells, red cells, more efficiently than a normal spleen. This is what's called hypersplenism, resulting in anemia. There are also other clinical entities, for example, extracorporeal circulation. So when patient goes for a heart surgery, bypass surgery, in order for the surgeon to operate on the heart, they have to stop the heart from beating, or else they cannot operate on it. So what they do is they put a bypass machine. They hook the patient to a circulating machine outside the body that takes the venous blood, oxygenates it, and returns it into the aorta to keep oxygenating the body while the heart is standing still for the surgeon to operate on. That machine is essentially a series of tubes where the red cells get attached to these tubes and they get destroyed. So you see a lot of hemolysis from that, because this is not the smooth membrane that you see with typical endothelial cells or blood vessels. So some of these red cells get destroyed simply from extravascular, extracorporeal circulation. Another rare entity, probably we don't see it anymore, what's called March hemoglobinuria. So this was observed in the old days when the soldiers used to march long distances, miles and miles and miles, and with each step they stamped their feet on the ground. As soon as when they hit the foot on the ground, the heel, whatever red cells in that heel, they can get destroyed from essentially stamping the foot on the ground. And pound, 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 with every step, you see some of these cells rising from it. This is what's called March hemoglobinuria. More commonly these days is due to mechanical valves. So somebody, they have a mitral valve or aortic valve replaced, and they put a mechanical, which is a piece of metal. Essentially, it acts like a hammer. With every heartbeat, it opens and closes. So whatever red cells it's stuck in there, it can get hemolysis, just like hitting the red cells with a hammer. Okay. So these are the macro circulatory processes. With microcirculatory processes is essentially destruction that happens in the small blood cells. I'm going to talk to you about DIC, TTP, and PNH, but importantly also to mention malignant hypertension and sepsis. When the patient has a very high blood pressure, there's a lot of vasoconstriction. You can end up with a small thrombi in these small vessels, and this will cause lysis of the red cells, both malignant hypertension and sepsis. You see it in there. So the three entities that cause microcirculatory hemolysis, the first is what we call thrombotic thrombocytopenia purpura, TTP. So normally in our body, as a normal process of control of bleeding, we have the von Willebrand factor. The von Willebrand factor is made mostly by the endothelial cells. And when it gets released by the endothelial cells, it usually gets released as a multimer, as large multimers. Okay, these large multimers are very active form of von Willebrand, and rapidly they get degraded in the plasma by a protease called ADAMTS13. Okay, it's a metalloprotease that degrades these large multimers. Okay, the smaller the monomers and the smaller multimers are less active than the large multimers. Okay. There are conditions when the ADAMTS13 activity is low, either as a familial, which is a congenital deficiency of ADAMTS13, or an autoantibody against ADAMTS13, which is a much more common what we see. So an antibody comes and destroys the ADAMTS13 enzyme. So the von Willebrand multimers do not get degraded. They remain as multimers, but they remain very active. So when they remain very active, they essentially cause activation of the platelet aggregation, and causing microthrombi in the small blood vessels. With these thrombi and in the small blood vessels, you have the red cells going through in there. There's a fibrin clot in there. This will cause, by shear pressure, essentially some shearing effect and destruction of the red cells. So this is essentially a hemolytic process that's happening in the small blood vessels. Okay. So historically, we've always been told that TTP, you have 5 signs that you look for, essentially thrombocytopenia and anemia, kidney failure, neurologic deficit, and fever. But these days, because people keep a very close eye looking for TTP, we rarely see this pentat. Really, anytime you see somebody who comes to you with thrombocytopenia and hemolytic anemia, you have to rule out TTP as a first entity, because early treatment with plasma exchange is very important, or else the patient will have irreversible damage. The second entity is DIC, which stands for disseminated intravascular coagulopathy. So as you know, you have the coagulation cascade and you have the fibrinolytic cascade that will put the brakes on the coagulation cascade. What happens with DIC essentially is you have uncontrolled activation in both the coagulation and the fibrinolytic system, both, and essentially usually sepsis and major infections or major trauma give you DIC. So when you have activation coagulation cascade in the plasma, you cause platelet activation, platelet microthrombi and clots in the small vessels, just like TTP. And this will also cause hemolysis of the red cells because of the small thrombi in the blood vessels. Okay. Importantly, in DIC, you can either have clotting or bleeding, because if it's mostly the coagulation cascade that's being consumed, you end up with bleeding. But if it's mostly the fibrinolytic pathway that's being consumed, you end up with clotting. So you can have either presentation. And importantly, so both DIC and TTP give you thrombocytopenia and hemolytic anemia. The way to differentiate is that in DIC, because you're consuming the coagulation system, so you end up with, if you do the tests for coagulation, you can learn about these two tests later in the course, PT and PTT. These that become abnormal because you're consuming the coagulation cascade. While in TTP, the PT and PTT remain normal. The third entity is called PNH, paroxysmal nocturnal hemoglobinuria. And it's essentially, this is a clonal disorder of stem cells. So important to notice, this is not a red blood cell problem. This is a problem in all the body cells. There is an enzyme called GPI, glycosyl phosphatidylinositol. I'm going to go to the next slide to show you the graph. So what you see at the bottom of the slide is the typical cell membrane with the biphospholipid layer, and you have this phosphatidylinositol, which it acts like an anchor protein. It's a protein that's attached to the cell surface, but to which multiple other proteins they get attached. It's just like an anchor, and other proteins get attached to it. And the two proteins we're most interested in are CD55 and CD59. These two proteins, CD55 and 59, are protective against the effect of complement. So if complement is activated, in order to protect the normal cell from being destroyed by complement, the CD55 and CD59 neutralize complement activation. If GPI, the phosphatidylinositol, is absent, this is what happens in PNH. These CD55 and CD59, they get released into the plasma and they get degraded. So you cannot find them on the surface of the red cell. So the red cell becomes very susceptible to lysis by complement. So that's why you see a lot of lysis with PNH, because it does not protect itself from complement. And an easy test to perform to diagnose PNH, essentially you can do flow cytometry and look for expression of CD55, CD59 of the surface of the red cells. If it's absent, this is diagnostic of PNH. And so on all of these entities, by the way, as I mentioned, with PNH, it's not only red cells, it affects all the cells. So the platelets, they also become susceptible to the effect of complement, so they get activated. So you have the thrombocytopenia. The neutrophils, they get also consumed, so you got neutropenia. So essentially you end up with pancytopenia rather than anemia alone. And also these platelets, when get activated, they can cause blood clots in unusual places. So anytime you see a patient with a clot in, let's say, in the portal vein for no reason, or some unusual location, think PNH, because especially if the patient has pancytopenia, this is the usual presentation. And all of these entities, the microcirculatory, DIC, TTP, and PNH, essentially have microthrombi in the small blood vessels, causing some lysis of the red cells by the shearing effect. When the cells is going through that small vessel and there's a fibrin clot in there, it loses a part of it. And this is what you see in the peripheral smear, these abnormal shaped red cells. This is what we call them schistocytes, typical finding on all of these entities. This is on electron microscopy. So the white is a fibrin clot, and this is the red cells essentially get stuck in the fibrin clot, and it loses its shape and goes through the microvessel. So that takes care of the microcirculatory process. With that's extracorpuscular. With intracorpuscular hemolysis, you have the effect either in the red cell wall or in the hemoglobin itself. And we divide these either a membrane problem and two entities under that, hereditary spherocytosis and elliptocytosis, or a metabolism, some enzyme deficiency, namely G6PD deficiency and pyruvate kinase deficiency, or abnormal hemoglobin. So with hereditary spherocytosis, this is an autosomal dominant disorder, and as you know, the red cells, they have this biconcave shape because for the same volume they can have a larger surface area to allow more oxygen exchange. And there is a cytoskeleton underneath the cell membrane that keeps the cell in this biconcave shape. Hereditary spherocytosis is any protein defect that makes the cell lose that biconcave, so it becomes a sphere, which is the easiest shape for any volume. So essentially, it's a defect in the vertical interaction between the skeleton and the lipid bilayer, resulting in a sphere. The cell becomes spherical, and these spheres, they don't go through easily in the reticuloendothelial system in the spleen, so they get picked up and degraded in the spleen. So what you end up with anemia of various severities, jaundice, splenomegaly, reticulocytosis. The way to test it is something called osmotic fragility test. Essentially, I think I have a slide on it. So this is you have the cytoskeleton of the red cells. Any defect on these proteins can result in the loss of the biconcave shape, and some proteins give you a sphere called hereditary spherocytosis. Other proteins give you elliptical shape called hereditary elliptocytosis. You don't need to remember which proteins gives you what entity. I don't remember them, but essentially a defect in the cytoskeleton that loses the biconcave. It becomes either elliptical elliptocytosis or spherical hereditary spherocytosis. And this is what you see in the smear. You see loss of the central pallor, and these are large spheres, unlike the microspheres that you see in hemolytic anemias. These are large spheres because the full volume of the red cells in there, and this is what you see in the hereditary elliptocytosis. And typical utilizing cells, you see pallor, you see jaundice, you see splenomegaly. Gallstones is very common because what's called bilirubin gallstones. You have a lot of bilirubin release, it can give you gallstones and the gallbladder. And the concept of aplastic crisis is very important, caused by parvovirus. So as you know, parvovirus can affect the bone marrow, causing temporary stop of the function of the production in the bone marrow for 4 or 5 days. So let's give you an example to explain what aplastic crisis is. I need you to imagine you have 2 tanks of water. Each tank can have 1,000 liters of water, so they're equal volume tanks. In tank 1, you have a faucet, 1-inch faucet that pours water into that tank, and you have at the same time a 1-inch faucet at the bottom that drains water from that tank. So that tank is in a steady state. You have 1 inch that's draining and 1-inch faucet that's pouring water into it. So the water level remains steady in that tank. Tank number 2, same volume, 1,000 liters, but instead of the 1-inch faucet in and out, you have a 5-inch faucet that drains and a 5-inch faucet that pours water into it. Okay? And the similarity is essentially the person with a normal hematopoiesis versus somebody with hemolytic anemia. So normally, you and I are making some cells at a steady state, specific number of red cells and specific number of platelets and so on, and we destroy the same number of red cells. Somebody with hemolytic anemias, because they destroy cells much faster, the bone marrow is much more active, so it's making much more red cells. So it's a much more active system. Okay? If a parvovirus infects that bone marrow, you and I, our bone marrow shuts down for 4 or 5 days. It's because it's a slow process. Our red cells survive for 100 to 120 days. We might see a small drop in hemoglobin, but we don't see a lot, okay? Because we don't consume the resources that we have, okay? Somebody with hemolytic anemia is very dependent on the production process because they consume a lot, so they're very dependent. If you shut down the production, you shut down that 5-inch faucet from that tank is going to get empty very fast. This is what we call aplastic crisis. So somebody with hemolytic process, they get an infection with pyovirus, all the blood numbers go down much faster. Another example is essentially, we see it also in oncology, patients with hemolytic processes who are getting chemotherapy. Chemotherapy also shuts down the bone marrow for a few days. You see a very similar process. The blood counts, they go down much faster compared to somebody who doesn't have hemolytic process. And this is the osmotic fragility test that we spoke about in hereditary spherocytosis. So essentially what happens is they put the red cells in progressively more and more hypotonic solutions, okay? So with the lower hypotonic solutions, the cells start to lyse. So normally, we have a normal range that you see in the yellow shade. This is the normal range where the red cells lyse. Somebody with hereditary spherocytosis, they're more susceptible to these lysis, so they lyse with less hypotonic solutions. We see that's what you see in the orange line. So this is how you diagnose hereditary spherocytosis. Next, we have some two enzyme deficiencies, namely G6PD and pyruvate kinase. And as you know, G6PD is the first enzyme in the pentose monophosphate shunt, and it is the reaction that's responsible for the production of NADPH. And NADPH it has a reducing power. Essentially, it opposes antioxidant stress. Fever, sepsis, these are all oxidant stress. And NADPH acts as a defense mechanism, as a reducing mechanism to avoid oxidant stress. If you have a G6PD deficiency, you don't make enough NADPH, so your red cells are more susceptible to the effect of oxidative stress. And we have two forms of G6PD deficiency, what's called the A type, which is the African type, or the Mediterranean type, which we commonly see in our region. And usually the Mediterranean type is the more severe type. So if you look at the instability of the enzyme in the African type is mild instability, while it's severe instability in G6PD in the Mediterranean form. The deficiency, because it's a mild deficiency in the African, it expresses itself in the older cells only, while the Mediterranean it's much more severe, so it expresses in all red cells. So its severity is definitely more pronounced in the Mediterranean type. And the G6PD level is important. So to diagnose this, we measure the G6PD level in the patient. So somebody comes to you with a G6PD, you suspect G6PD deficiency, hemolytic process, you can measure the G6PD level. In the African type, because the older cells have died, these are the cells that have lower G6PD. If you measure the G6PD level in the acute process, during the acute hemolytic process, you're measuring G6PD only in the young cells, you might falsely reassure that this is a normal G6PD level, because only the young cells that have a good G6PD level are still surviving. So it's not a good idea to test during the acute hemolytic process because you're testing only the young cells. So what's recommended, you wait for a few months and test. This is when you do the test on both young and older cells, leading to proper diagnosis. While the Mediterranean, because all the cells lies, the G6PD might be low even during the acute episode. Hemolysis to fava beans is essentially food. So this is common in the Mediterranean type. If you heard the term fawwal, somebody fawwal meaning they ate food, like for example a sandwich of falafel, they can have this hemolysis because of that. And this is essentially, you've seen this slide before, when you have this hemoglobin get deposited in the cell called Heinz bodies and gets picked up in the spleen. And it can also give you intravascular hemolysis if it's massive, giving hemoglobinuria and hemoglobinemia. And it is X-linked, so the typical pattern, the mother is the carrier and it transmits the disease to the son. So as I said, it's X-linked, rapidly in developing intravascular hemolysis. You end up all the signs of hemoglobinuria and so on. and you see all of the abnormal cells, the bite cells and so on, when these cells get destroyed in the spleen. And Heinz bodies is essentially a deposited hemoglobin in the red blood cells, and we diagnose it by measuring the G6PD level. And these are the bite cells. Essentially, when the red cells, they go through the spleen, essentially when you have the Heinz bodies that you see on the right side of the screen, these are the Heinz bodies. So when these go to the spleen, the macrophage takes a bite to remove these Heinz bodies, you end up with what's called bite cells, that the ones you see on the left side of the screen. And there are really multiple entities that can cause G6PD. Any acute infectious or acute illness, diabetic ketoacidosis, sepsis, and so on, and lots of drugs that can cause that. And of course, fava beans, as we said. Treatment essentially stop whatever drug is causing it, transfuse the patient as needed, hydration, make sure the process resolves over time. With pyruvate kinase deficiency, it's very similar to G6PD, but it's much milder. Okay, so it's not X-linked, it's autosomal recessive. You see various degrees of anemia, jaundice, gallstone, and the reason it's much less, it's milder, is because of the production of 2,3-DPG. As you remember from the glycolytic pathway, from the destruction of glucose, the last step, the conversion of pyruvate to lactate, is the pyruvate kinase. So if a pyruvate kinase deficiency in that last step, you feel less the effect of the hypoxia because of the shunt higher up. You have the 2,3-DPG, and as we saw in the last lecture, when you have 2,3-DPG, it causes the left shift in the oxygen dissociation curve and easier release of oxygen to the tissue. That's why the symptoms with pyruvate kinase deficiency are milder than those with G6PD. Last is we have some causes of hemolysis as abnormal hemoglobin, essentially sickle cell and thalassemia and hemoglobin C. You can have lectures about each one of these. So that will take care of the non-immune. The immune-mediated part, as we said, are essentially, we divide them into cold agglutinin versus warm agglutinin. Okay. And it really depends on the antibody that's causing the hemolytic process. Okay, the cold with the antibody that's causing that, it can be an IgG or IgM. Okay, and you can easily measure for the presence of that antibody on the surface of the red cells. This is what's called the direct Coombs test. You look for the antibody on the surface of the red cells. Sometimes you can test for the antibody in the plasma, circulating plasma. This is called indirect Coombs. But if you look for the antibody on the surface of the cells, it's called direct Coombs test. So the warm antibodies are usually IgGs. They react mostly at 37, and they're usually mild. So most of the instruction is extravascular. Essentially, you support the patient, you give them a transfusion, and you give immunosuppressive medication to suppress this autoimmune process with steroids, splenectomy, and so on. The cold agglutinin and many antibodies, many medications, penicillin, quinine, can cause that. The cold antibody called autoimmune hemolytic process is much more serious. So it's essentially associated with some lymphomas or infectious mononucleosis, and it is IgM mediated. So when you have IgM, as you remember, IgM is a peptide rather than a monomer. So this will lead to complement activation. So the process of cold or autoimmune hemolytic anemia is much more serious. It usually acts best at 4 degrees, and because it's much more impressive, it can cause both extravascular and intravascular hemolysis, and really mortality rate is quite high from that. Okay. Very importantly, as a small tip, so to the left you see the normal smear, to the right you see this agglutination of the red cells. Because of the cold agglutinin, the IgM has a peptide, so it cross links between different red cells. So the red cells are attached to each other. So when you do a blood count on these patients, what we call CBC, complete blood count, as you remember from last lecture, there's some called the MCV, the mean corpuscular volume, the average size of the red cells. In here, you might have a falsely very high MCV because the red cells are attached to each other from the antibody. So when you see an MCV that's very high, 130, 140. This is not a physiological. This should give you a hint that maybe we're measuring 2 cells rather than 1 cell, and this might give you a hint that it could be a cold agglutinin process. Okay? And this is a much more serious process because really it causes massive extravascular and intravascular hemolysis. Thank you, and this is the end of the presentation.